Good morning. Happy Wednesday from France. My wife and I took the Eurorail in yesterday from London, arrived in Paris around 2 in the afternoon, and I started some research while on the Eurorail. Jet lag caught up with us pretty good. We went to bed about 9 p.m. last night, and I woke up probably 4:45 this morning and continued some of that research. We are just about 30 minutes from sunup here in Paris, which will be about 7:15 or 7:30 this morning. What we're going to review today is a little more advanced, and this isn't something that many of you in your practices are going to do, and that's completely fine, and I understand that. But I do get requests from providers looking for more action steps that they can take to prove that what they're doing is actually making a clinical impact for their patients. Now, again, I've got to do a little homework on my own because some of what we're going to discuss today is not commercially available. And so I've got to make a few calls and see how we can make this more commercially available to all of you. Long story short, if we're looking at the literature, and as you all know, I'm perusing it on a regular basis, if you were just to query chat and you were to say, give me the single best possible allograft with demonstrable proof that if I were to apply this in my office today, that I would see some measure of positive collagen-rich differentiation of type 2 collagen, articular cartilage. Now, chat will pull information from PRP, and there's some very, very good articles that are PRP articles demonstrating not specific formation of collagen type 2, but some precursors, urinary precursors that were demonstrated to be beneficial when measured in patients that were given PRP. Now, there are two primary urinary precursors, meaning that if I sample your urine, I can determine whether your body is enzymatically breaking down type 2 collagen. I can also determine whether your body is breaking down type 2 collagen from an inflammatory standpoint. The enzymatic breakdown of cartilage we can test in the urine through something called urinary CTX2. This can be done on a lab test. You have to actually go through a specific subset of laboratory markers offered by LabCorp under their clinical trials subsection. The second and more interesting subtype is a nitrated urinary collagen type 2. It's UCOL2, and I believe it's like NO2. This is only prevalent when we have inflammatory breakdown of type 2 collagen. And essentially, if you had a baseline from a patient and then you repeated this urinary test in 3 months, 6 months, and 12 months, reduced levels of urinary CTX2 and urinary nitrated collagen type 2 would demonstrate that your body is not breaking down type 2 collagen. The available articles, and they're very robust articles, that demonstrate reductions in urinary collagen subtypes using PRP, most of you cannot do in your offices. And the reason you can't do them isn't because of the lab tests. It's because the doctors who are performing these PRP applications had laminar hoods in their office with like ISO 7 certified clean rooms. Now, a laminar hood is probably a $100,000 investment just to do PRP in your office. That's not practical. No one's going to go out and spend $100,000 for a laminar hood just to prepare a $150 PRP kit or $250 or whatever. It's complete nonsense. And so anytime these PRP folks are jumping up and down and screaming and yelling and say, hey, PRP's got this crazy literature. Sure, it's academic literature. It's not clinically accessible. It's not clinically practical. And this is what I hammer over and over and over again. If you are perusing literature, if that literature is not clinically actionable and you can't use it in your practice tomorrow, what good is that literature? It actually has no clinical bearing as far as I'm concerned. It's strictly academic literature. What I have tried for probably 150 lectures or so here is to build a fund of knowledge that is immediately clinically accessible, duplicable, and any doctor watching this can reproduce this in your practice tomorrow. The strongest clinical literature that we have for enhancing collagen-rich differentiation of type 2 collagen is still with Wharton's jelly. The practical application of that allograft as it is used in a doctor's office day in and day out is still the most elegant, the least burdensome, and has the best potential outcome to enhance articular cartilage collagen, which is type 2 collagen. For those that are interested, many of you are now aware that we will be starting a randomized controlled trial, a patient-reported outcomes randomized controlled trial. And for the vast majority of you that might be interested, this is going to be good enough. Couple applications of PRP, couple applications of Wharton's jelly, simply getting a patient to fill out a JOT form that's 20 questions long, not 15, made specifically for an IRB-approved, randomized controlled comparative trial that we will be starting through the Institute of Regenerative Education probably in January. We are going through the process of formalizing that paperwork with the IRB as we speak, meaning like right now. However, some of you have a screw loose, kind of like me, and you want more meat on the bone. You want something else that you can do in your office where you can prove to yourself and prove to your patients that you are affecting positive change if you are in fact using a Wharton's jelly product, whether that's cryopreserved or lyophilized. And so over the next week or two, I'm going to make some phone calls to LabCorp. I'm going to see if we can, through the Institute of Regenerative Education, get a clinical trial passport or something to that end, where any of you that would want to order these specific urinary screens in your office will be able to do so. Should you want to participate in this national and international comparative trial, we will be having a very large and a very public lecture on this, probably sometime mid-January, maybe earlier, maybe in December, where we'll be announcing the IRB-approved randomized comparative trial. It will be a patient selection randomization, meaning patients will choose whether they want PRP or Wharton's jelly. You'll be able to charge patients for this, so this will be a cash-based procedure. And it'll be a simple comparative, kind of like the Coke-Pepsi challenge, where patients will decide for themselves whether PRP or Wharton's jelly is more efficacious for them, improves their quality of life better, reduces their pain better, helps them sleep better, these type things. Some of you may want to do a bit more. We'd looked at weight as a measure. We'd looked at steps per day as a potential measure, none of those were exciting enough for me, to be perfectly honest. And so what we're going to try to do is get approval from LabCorp. And if you would like to track these urinary collagen-based studies on your patients, it would be 3 or 4, maybe 0, 3, 6, and 12 months, right? And again, looking at the enzymatic breakdown of collagen, UCTX2, and the urinary breakdown from an inflammatory standpoint of collagen, which is a nitrated urinary collagen type 2, wherein, again, reductions in the presence of these urinary type 2 collagens would demonstrate, obviously, more retained type 2 collagen in the knee compared to baseline. As always, I'm dropping receipts. There will be a very long list of information below this lecture to show the rationale for how and why we would use this, some of the really good foundational literature that demonstrates that Wharton jelly does enhance collagenous differentiation of type 2 collagen, and then a bit of background on urinary CTX2 as well as urinary nitrated collagen type 2. Again, I'm Dr. Martin. Looking forward to your participation in this very, very large comparative OA knee trial, and just a little something for you all to chew on, because we're always trying to give you more action steps that you can take in your own office to not only prove to yourself, but also prove to patients that what we're doing is affecting patients in a positive way and in an objectively measured way. Please, everyone, have a very safe and blessed day.